So here again at the ASH 2024 annual meeting, I'm Jeff Lancet and I'm joined by Dr. Julio Chavez, who is one of our faculty members in the lymphoma section, also the clinical research medical director for immune and cellular therapy for hematologic malignancies. And Julio, your interest is in lymphomas, and there's been obviously an explosion in new therapies, targeted therapies, immune therapies in lymphomas over the last few years. You've been involved with a lot of this. What are one or two of the highlights of new targeted therapies at ASH this year that has you excited?
Yeah, I think the most, probably the new targets I'm interested are the CELMoDs, which are like new immunomodulatory drugs that the properties are they're more effective than traditional CELMoDs like lenalidomide, but also they're easier to give to patients, so they don't need to do the hospitalization, all the logistics that we require for instance, CAR T-cell therapies or bispecific antibodies. And we have an oral presentation in diffuse large B-cell lymphoma, and we have a poster also in follicular lymphoma. I think the results are promising, and I think offer an alternative for patients that don't have access to high-risk immunotherapy. I think it's a good thing to do. So I'm very excited about those. The other target is a CD19 bispecific antibody that is probably the only one that is in development for lymphomas, the follicular and diffuse large B-cell lymphoma that one of my colleagues, Samuel Gabal, is presenting. I think having a different target for bispecific is always important, especially for patients who haven't been exposed to CAR T-cell therapy. So that's one that kind of like is driving also my interest.
So you've done a lot of work in immunotherapy and lymphoma, both cellular therapies and now non-cellular bispecific antibody therapies. And it seems as though these bispecific T-cell engaging therapies are really developing an important niche in a variety of different lymphomas, but now they're being combined with other targeted drugs or even other immunotherapy drugs. Tell us about your work in combining a bispecific antibody with a more traditional antibody therapy.
Yeah, I think one of the probably most important features of bispecific antibodies is that they can be combined easily or easier than CAR T-cell therapy. So that's kind of like one of the reasons why we started this clinical trial with an FDA-approved drug with polatuzumab vedotin that is being approved for several years in combination with mosunetuzumab. And actually the study that I'm going to present tomorrow is actually telling the story about this combination and efficacy, and we had a very good efficacy and a very good progression-free survival in highly heavily pretreated patients, including post-CAR T. But not also that, we also saw a decrease on the cytokine release syndrome rate. So from traditionally, a bispecific antibody has a rate of CRS between 40 to 50%, maybe 70%, mostly grade 1. But for this combination, we were able to reduce the toxicities to less than 15%, 10% range. So I think that's remarkable because this regimen was fully outpatient. It didn't require any admission, so offers the opportunity to do it safely even outside main cancer centers. So I think that's what we're excited. There is a mechanism behind that, less tumor burden. You have depletion of B cells that also kind of helps with the management of toxicities, and so.
It's pretty amazing at the explosion of these new immunotherapies. And I guess one final question is, with both cellular and non-cellular immunotherapy taking root in lymphoma, how do you see these playing out? Do you see certain patients going towards one mode of therapy versus another, or do you see them sort of being used sequentially?
I think I see it more like being used sequentially, because even with these therapies, even with CAR T-cell therapy in the second line setting, we don't cure all patients. Still there is a high bar to beat. Although it's still like, there is an unmet need in that regard in aggressive lymphoma. So I think I'm seeing that more like a sequential treatment between, do CAR T, then followed by bispecific antibodies based on some type of correlative data, such as, minimal residual disease. So I think there is a lot to explore in that regard. We still don't understand what is the right sequence. but I think we're getting to the point that we're going to cure more patients, so that's kind of the bottom.
That's the key.
So,
There you have it, lymphoma expert Dr. Chavez. Thanks for joining us.
thank you for having me, and enjoy the meeting.
You too.
Yeah, okay.